Well, good morning, everyone. Thank you for joining Otometrics for one of our free webinar presentations entitled Tympin Ain't Easy, Pediatric Immittance Test Battery. I have a few introductory slides to go to, and then we will get started with the presentation. Let me just minimize this here to make sure we can see the screen. There we go. All right, so my name is Brianna Young. I am the Global Hearing Assessment Product Manager for Otometrics, an audiologist as well. And I'd like to introduce our two presenters for the day. Our first presenter is Dr. Dawn Violetto. She is a pediatric audiologist and the Director of Audiology at Child's Voice School in Wooddale, Illinois. For those of you outside of the US or maybe not familiar with that school, it's a school for children with hearing impairment. Most of the population wears hearing aids or cochlear implant, or some of them are bimodal as well. And then our second presenter is Dr. Lindsay Bondurant, and I apologize because I probably butchered your name. She's also a pediatric audiologist and the director of the Pennsylvania Ear Institute of Sallius University in Elkins Park, Pennsylvania. I do have a few tips and tricks to go over before we move on to the rest of the presentation. First of all, just so that you're all aware, all of the microphones for the participants are muted to reduce background noise, and they will be muted for the duration of the presentation. If you'd like to ask questions during the session, there is a question box in your webinar menu bar. Once all of those questions are collected at the end of the session, we'll go ahead and we'll take 5 to 10 minutes to go through as many of those questions as we can. If for some reason we don't get to your question, or maybe you think of another question, I will put my contact information up at the end of the presentation. So all replies can be emailed to me afterwards, and then I can act as a conduit to get your questions to Dawn and to Lindsay. If at any time you experience technical difficulties or you need immediate support during this webinar, please message me directly to the moderator. And I apologize, I am not Mariana, I missed this slide. I am Brianna, so send all of your support requests to me via the chat function and I'll do my best to assist you. Okay, so let me go ahead. Now what we're going to do, and just so that you're aware, we are doing a multi-country and multi-state presentation for you today. So I'm currently sitting in Illinois, as is Dawn, and then Lindsay is in Pennsylvania. So let me go ahead and share the screen with Dawn, and she will kick off the presentation and I think introduce herself and Lindsay a little bit further.
Good morning, everybody. I hope you can all hear me well, and I hope you all have your coffee filled up as I do. Not quite enough coffee yet, but hopefully it'll get me through. My name is Dr. Dawn Violetto. I am a pediatric audiologist and director of audiology at Child's Voice in Wooddale, Illinois. I've been practicing audiology for 26 years. I have a bachelor's and master's from Northern Illinois University and a Au.D. from A.T. Still in Arizona. And with me today is my friend, Dr. Lindsay Bondurant, and she is also a pediatric audiologist and is director at Pennsylvania Ear Institute at Sallius University in Elkins Park, Pennsylvania. She has her bachelor's from the University of Florida, her master's from Vanderbilt, and her Ph.D. from the University of Texas at Dallas. And there we all are. Sorry, I forgot to change my screen here. So our objectives for today is we're going to look at the need for a pediatric test battery for immittance. We're going to talk about the different anatomical and physiological differences between adult and pediatric ears and the need and how that dictates the need for different measurement parameters. We're going to talk about what's in an immittance battery and its components. And we're going to talk about the differences in the batteries for below 6 months and above 6 months. And then we'll kind of wrap it all up at the end. So the question is, why should we care about Eddie even if we're not pediatric audiologists? And I'm sure there are a few of you in the audience that are not pediatric audiologists and maybe don't see many kids in your practice. But we know that undiagnosed hearing loss is very detrimental to babies and children, and it really reduces their access to language and has a deleterious effect on not only their educational outcomes, but their social and emotional ones too. Au.D programs are focused on identifying and managing hearing loss as early as possible for all infants, so they have access to that critical language as soon as possible. See, this baby's very sad about not having access to sound here. In the U.S., almost 4 million babies each year are born, and about 8,000 of those will be born with some form of significant hearing loss, whether that's one ear or both ears, mild, moderate, severe, some form. At this time, at least in Illinois, because it's different by state, about 98% of babies born are screened prior to discharge. And some say, well, why not 100%? Why aren't all babies screened prior to discharge? And that is because, unfortunately, there are some babies that do not make it out of the hospital. They expire prior to screening. Some parents decline to have their babies tested due to religious reasons, or they just don't care to. And then also some babies are transferred out, or to maybe to higher risk centers, and hopefully they get caught and screened there before they're discharged from those places. Of those that are screened, an average of 3 to 4%, at least in Illinois, will fail the initial screening. And of those that fail the initial screening, about 1 to 2% will fail the second screening, also in one or both ears. Often those screening entities, which are typically in Illinois now, many of the screening entities are hired companies that come in and do the screening. It's no longer like the nurses that do it. Pediatrics is one, Natus is one, and they will do not only the hearing screening, but like PKU and other infant screenings that are done after they're born, CMB, if they're starting to do that. They will often do the first screening within 24 hours of birth, and then they will do a second screening, hopefully within that first 24 hours or 36 hours prior to discharge. And sometimes the third screening is done as an outpatient. They come back and they're rescreened for a third time. However, if the baby is a NICU baby, they get 2 screenings and they're out. 2 screenings, if they fail, they get referred to diagnostic right away. And that's the way it should be done. And that's based on those Joint Commission of Infant Hearing recommendations. If we delay those screenings or delay getting to diagnostics, of course, that's only going to further delay the risk of lack of language development. So one thing that should never happen is you should never screen till a baby passes, which sometimes can happen, unfortunately. I do still get parents that come in and say, oh my goodness, they did the screening like 8 times. And it's like, oh, that's not the way it should have gone. And so that also has delayed that baby getting to me to do the diagnostic as well. So JCIH recommends that babies are screened prior to discharge from the hospital and then rescreened within 1 month, as we just said. A child who fails that rescreening should be referred to somebody like myself or a diagnostic ABR, and that should be done within the first 3 months. If the child's diagnosed with hearing loss, then they should start an intervention prior to 6 months. So that's what's called the 1-3-6 rule. That's what JCIH recommends for newborns as far as timing goes. We'd like to see that change. I mean, it's not like we just say, well, as long as we do it by 3 months, we're good. I mean, a lot of times I'm seeing these babies now at 8 weeks for a diagnostic testing, which is amazing. And then if I do diagnose hearing losses, we can fit them with hearing aids, hopefully within weeks of that. So we're not sticking to 1-3-6. We want to improve on 1-3-6. We always want to make it better than what it is. But that is their broad recommendations. So as we know, 64,000 babies could possibly fail this screening. So clearly there aren't enough pediatric audiologists in the country to see all those babies that fail screening for follow-up. So having people that, out in the community that are audiologists that could see the babies and have a good idea of what needs to be done with them is also very, very important. Every team member in this baby's life plays a role in making sure that we're, diagnosing hearing loss and managing it for these children. So what about the immittance battery? Why does it matter with all these little ones coming in? Well, it actually matters because studies have shown that 33% of these babies who refer on diagnostic testing may have middle ear dysfunction, and that may be why they've referred, at least in one or both ears. Most of us have an immittance bridge, so we can test infant ears and rule that in or out. Even if we're not the one who's doing the diagnostic testing, we can at least rule that in and out as a transient pathology, hopefully. I would say that the babies that I see here, we often see them about 6 weeks of age, and seeing that middle ear dysfunction is common in one or both ears. So it definitely is something that you're going to see if you start seeing little babies in your office. All right, so back to basics. Let's take a quick review of immittance, the immittance battery, and what information that gathers for us. So immittance is a general term which includes impedance, which is the resistance to the flow of energy, and also admittance, which is the ease of the energy flow. The battery gives us information about basically the functioning or patency of the ear canal, the integrity of the eardrum. For example, is it moving readily? Is it moving as we expected, less than expected? Is it perforated? And also, if PE tubes are present, are they functioning or not? It also gives us information about the middle ear functioning or dysfunction, along with eustachian tube functioning. Also, information about the ipsilateral contralateral neural pathways up to the level of the brainstem through acoustic reflexes. And this battery usually includes tympanometry, acoustic reflexes, and decay, though typically for newborn infants, we're not testing decay. Typically, reflexes is kind of where we stop. And all of that together is what we call our infant protocol or battery. So now I am going to turn it over to Lindsay, and she's going to take us through more of a review. Lindsay?
All right, thanks, Dawn. So I'm the lucky one who is tasked with doing a review of some of these portions of a general immittance battery. And I jokingly say that I'm lucky to review that for you because I'm sure everyone listening is thinking, I spent a ton of time in grad school learning all of this stuff. It's all familiar to me. Why do I have to learn it again? I just want to review it because I want to hit on a couple of things that are common to immittance batteries and the things that you know already, because after this review, Dawn's going to sort of pull it back into what is different about the infant immittance battery. So if it's kind of fresh in your mind, that's going to make that a little easier to swallow later. So bear with me. I'll go relatively quickly for this because it is a review. So when we're talking about the immittance battery, there's sort of the two primary parts that we're talking about, as Dawn mentioned, is tympanometry and acoustic reflexes. Most of us do tympanometry on a fairly regular basis. It measures the acoustic impedance and the admittance within the middle ear space. When we're doing that, it provides information about the overall functioning in the ear canal, the tympanic membrane, the middle ear, the eustachian tube. So when we do this, we introduce an acoustic signal at different frequencies, and then we vary the air pressure about above and below the atmospheric pressure levels. So that the fact that we're introducing that acoustic signal and then varying the pressure comes in is very important when we start talking about infant testing. All right, so looking at the tympanometric parameters, again, just a quick reminder of what it is we are typically looking at when we do tympanograms just on anybody. We're looking at 4 primary parts. A lot of us are only looking at 3, but we should really look at 4. I'll talk about the equivalent canal volume, the tympanometric peak pressure, the admittance, and the tympanometric width or gradient. All right, so one of the first things that we look at when we're doing a tympanogram is the equivalent canal volume, or ECV. This is giving us information specifically about the status of the ear canal. So because this measurement is sort of getting information from the tip of the probe all the way to the TM, it can tell us whether or not that canal is open. Is something blocking the canal, like a growth or cerumen? Is there a foreign body? Is there discharge? If there's been surgery on there, you know, how big of a canal are we talking about? If the person has PE tubes, it gives us the status of the PE tubes because it will also measure some of the middle ear space. So it's really useful information to have when we're trying to figure out just what we're dealing with in that ear canal, which is really critical when we're dealing with infants where it's really difficult to see into that ear canal. We look at that, comparing it to normative data, which is often presented by age. The next thing as audiologists that we're typically looking at is the admittance measure. So we used to, a long time ago, we called this the static compliance. We don't call it that anymore because that is not really accurate. We're looking at the admittance measurement, which is measured in millimos and shows us the greatest amount of acoustic energy that is absorbed by the middle ear as we're putting that probe tone into the ear canal. So that gives us some information about the presence or absence of occlusions in the ear canal, the integrity of the tympanic membrane, the status of the middle ear space. And you can see on this slide, there's kind of a series of tympanograms. They all have the same peak pressure at 0 decapascals, which we'll talk about on the next slide. But it shows you some of these different admittance measurements. And so, you know, the very tallest peak there shows us an eardrum that is has a lot of admittance and is, you know, what we typically call a floppy eardrum. It's moving more than we want it to. And then as those peaks go down, we have poorer admittance until we get to sort of a flat line there that might tell us that there's fluid or something else going on in the middle ear space. Next, we are looking at the tympanometric peak pressure. And so that measures the pressure within the middle ear space compared to atmospheric pressure, measured in decapascals, which I just mentioned, and that gives us a little more information about middle ear health, ossicular chain integrity, effects of surgery, eustachian tube function or dysfunction. This is really useful information, particularly with older children and adults, to give us a sense of that eustachian tube dysfunction, and we use that all the time. Finally, the fourth parameter that I'm hoping we all look at, but I think sometimes gets lost in the shuffle of those other three measurements, is the tympanometric width or gradient. And it measures the steepness of the slope near the peak of the tympanogram, also measured in decapascals, gives us a little more information about middle ear pathology, scarring on the TM, tympanosclerosis, ossicular dysfunction, middle ear effusion. So when we're looking at a really wide tympanogram, that's usually indicative of poorer middle ear health and possibly is an indication that we need to refer that person for some medical management of that. We want to see a much more narrow tympanogram with a sharper peak. Next, really quickly, I'll review acoustic reflexes. I think a lot of you, especially if you are newer grads, you have seen this wonderful graphic from the from Utah State University that shows the acoustic reflex pathway. And what we're looking at there, as you know, is we want to see the stapedius muscle contraction in response to a loud acoustic signal. So for standard pure tone acoustic reflexes, which is what we typically do with adults, we start stimulating around 80 or 85 dBHL. We max out around 105 dBHL. And the absence or presence or elevation of those acoustic reflexes can help us in some differential diagnosis of peripheral or central disorders. So what this is useful is kind of a quick and easy way to gather some information that includes not just the middle ear and the cochlea, but also the 8th nerve and the 7th nerve, and a little bit of the lower brainstem pathways. And so that can really help in detecting or ruling out sensory hearing loss as opposed to neural hearing loss. So that was a quick and dirty review of admittance testing, and we want to make sure that we are including it as part of the infant diagnosis workup, because if we are really working on trying to get that diagnostic done as JCIH and the Au.D protocols recommend, we're trying to get it done by 3 months of age, we have to include that admittance battery and not forget about it, because so many of these kids, as the data shows us, up to 1/3 of these infants have middle ear involvement that could potentially be playing a role in the reason that they're referring on their newborn hearing screenings. So it'll help us make the appropriate recommendations for follow-up testing and possible treatments. All right, and in my facility, and I think this is what Dawn's facility is also doing, this is pretty common, the immittance battery is just part of that comprehensive diagnostic battery. So we do that as we're investigating whether or not hearing loss is present in both ears or one ear. We start with the health and history overview, but we always are trying to do otoscopy. I will say as a side note that doing otoscopy on these little itty bitty infants and newborns is really difficult, and it's very, very hard to see the TM. So we try otoscopy to kind of get a sense of what that ear canal it looks like in terms of debris or any discharge that's in there, and then we move on. The tympanometry is what is going to give us the best sense of what's going on with that ear canal and the TM. And then we move on to the reflexes, and then the more traditional part that we consider the diagnostic battery of DPOAEs and diagnostic ABR. So we need to do all of that differently for infants, not just because they're smaller, so it's not just a question of picking the right probe tip and picking the smallest one for us to use for this. Infant ears are much different than adult ears, and we need to change almost everything that we're doing in this immittance battery. So the anatomical differences, one of the biggest issues that we find is that for adult ears, they tend to be more stiffness dominated at low frequencies. So when we're using that standard 226 hertz probe tone, for adults, that's going to give us accurate information, but infant ears are more mass dominated at low frequencies. So if we use that 226 hertz probe tone, we're going to get potentially some really inaccurate results. So I've listed on this slide, and you can refer back to this later, some of the reasons why it's so mass dominated. But the bottom line is we have to use a different probe tone for tympanometry if we're going to get accurate results on infants. And with that, I'm going to turn it back over to Dawn to talk about exactly what we're doing with those young infants to get accurate results.
All right. So as Lindsay just indicated, the studies that are out there have shown that a 226 hertz probe tone when used with infants under 6 months is not sensitive to middle ear effusion. Even in the presence of middle ear effusion, you will see what looks like a nice peaked tympanogram, which is shown here on the right, though sometimes it will often have a double peak on there. If you looked at that and you said, oh, this looks great, it looks like a normal functioning eardrum, just kind of a funky 2 peaks there, I'm just going to go ahead and do my diagnostic ABR. First off, you probably see absent reflexes, and then you do the ABR, and it would look like it showed that there was some hearing loss there. So you would incorrectly diagnose this baby as potentially having some hearing loss, when in fact it could just be middle ear effusion. So with those little ones that are under 6 months, with that mass-dominated system that they have, we need to use a higher probe tone. With normal middle ear function and 1,000 hertz tone, you'll see what can look like the tympanogram on the left there, which is kind of a nice peak. So even though you're using a different probe tone, the tympanogram looks like it would on a 226. If you see middle ear effusion, very often what I see is a tympanogram that looks like the one on the right, which, as we all know, call it is a flat tympanogram. Sometimes you'll see kind of around it, and then it tails off in the negative pressure very low. So it can also look like that as well. So, you know, a normal tympanogram should look still normal for a baby using 1,000 hertz probe tone. So also looking at acoustic reflexes in young infants. So we all know that we can, on our equipment, we can do pure tones, we can do 500, 1, 2, and 4. It's a nice part of our battery, as we said before, because it gives us information about the cochlear and cranial nerves. And helps us differentiate between cochlear and retrocochlear disorders. However, we have to recognize that the presence of reflexes is susceptible to middle ear abnormalities. So something going on in the middle ear, you're not going to see those reflexes come up. And here's some norms for reflexes that we just kind of want to throw this slide in here so you can refer back to them at a later date if you need to. But what we would like to talk about is the use of a broadband noise acoustic reflex signal in your battery, which for most people, if you don't see infants or young children, you might not think about using. You might have seen it on your mittens bridge. But you thought, well, I don't know what that is, but I'm not going to use it. But it actually is quite a useful tool for us in the infant battery. A lot of times when we start testing, these babies are awake, and you start sticking things in their ear and looking in their ears and prodding in their ears. They're not very happy. They're crying. They're fussing. All of that will show up on your screen if you're running reflexes at pure tones. You'll see lots of noise appearing on your screen. So going in and using a broadband signal, studies have shown that infants with normal hearing, and of course dependent on normal middle ear function, will have a broadband acoustic reflex between 55 and 75 HL. So again, this is a really nice quick check, pulse check of this child's sensory function. So this image here from J. Hall et al. Is his study showing that the difference between pure tone reflexes and broadband reflexes in the ear of infants. So what you're seeing is that when we look at the pure tone signal, which is the dashed line, excuse me, that the reflexes are relatively stable. They don't really change dependent on hearing loss. So we have acoustic threshold on the left and hearing loss on the bottom. So they pretty much stay the same. They don't really change as far as where you're going to see those acoustic reflexes until you get between like 55 and 60 dBHL. And then as the hearing loss gets higher than that, more than that, the reflexes will start to elevate. As opposed to the broadband signal, what you see is the broadband responses start to elevate in a fairly linear fashion as the hearing loss in thresholds does as well. So again, we'll see these between 55 and 75 in a normal ear. So I really like to include these, and actually I spoke to Jay Hall once, and he's like, you really should do, and I started doing it, and you know what, it's really great. So I would definitely, if you haven't thought about including this into your battery, definitely think about including it in the future. So back to our recommendations for a baby under 6 months. Otoscopy, you definitely want to look at that. Again, like Lindsay said, I totally agree with her. The chances of you getting a good look at the eardrum on these little ones is pretty remote. I mean, the average age of the ones that we're seeing here is 6 to 8 weeks. Those ear canals are tiny. They're very floppy. They're prone to collapsing. If you can get a good look in the ear canal and make sure it's not occluded with any vernix, that's a good day. So relying on the tympanometry to let us really know what's happening at the level of the eardrum and beyond that, and then looking at our ipsilateral, potentially contralateral acoustic reflexes. But again, a lot of times if we can get ipsilateral ones, we're happy with that as well. So putting it all together, we use the information that we gather in tympanometry to decide in my practice, and I'm just talking about in my practice here, we use TIMPs and reflexes on the initial valve to decide whether we're going to proceed further with our diagnostic ABR testing. If the TIMPs are normal, and we proceed with reflexes, OAEs, and the ABR. If the TIMPs are abnormal, we usually defer, and sometimes just only on the one ear that's abnormal, and we'll go ahead and test a normal ear until a later date. In my experience, about 80% of our babies that we see here that have an abnormal TIMP, when we follow up 6 weeks later, it will be normal, and we can proceed with the diagnostic ABR. About 20% of those ears are still not normal, our 6-week follow-up, and then that for us, for me, we automatically refer them out for treatment, whether it's through their medical home with the pediatrician or whether it's through an ENT. I do not want to keep seeing this child back week after week after week and seeing a flat TIMP. If I've seen a flat TIMP twice, out the door you go, let's get some treatment, and let's see you back. Sometimes it takes them 4 weeks to get an appointment with an ENT. And oftentimes, if there's any question, the ENT will sometimes do a myringotomy and then do the ABR after that. Sometimes they get no treatment and I end up seeing them back after that. And then often they will give them treatment and then we'll see them back for their diagnostic ABR. So, the question is, why do you just not do it anyway, even if you see an abnormal tympanogram? Well, because it really takes a long time to do an unsedated ABR, and to do an unsedated ABR on an ear that is not functioning, middle ear is not functioning correctly, you're just going to have to come back and repeat that ABR anyway. So as far as being efficient in the practice and efficient for parents with this newborn baby, often it's a better choice to defer doing the ABR on that day, wait for that middle ear to clear, and then come back and do it on another day. So looking at our pediatric battery, we've got otoscopic examination of the outer ear, the ear canal and the eardrum, look for pits, look for tags, look for position of the ears on the head. Are they tipped or cupped? Are they low? Doing our 1000 hertz TIMP, looking for a normal shape and admittance, measuring reflexes, measuring OAEs at 12 frequencies, because you all know you can't bill for 6 now. Doing your diagnostic ABR using tone bursts at a high and low at minimum. We use a click to just look for neural function, and then we do a high pitch and then a low pitch at a minimum. And then basically, using that battery approach is most important. So you've got your cross checks between the tests that you're doing. And again, like I said, even if we see one ear that's abnormal and the other ear is normal, I'll go ahead and test the normal ear because these guys are in my office. I'm not going to not do something while they're there, and parents are very appreciative of not to be there for 3 hours sometimes. So let's look at our must-haves. We've talked about our battery. That's kind of like our must-have for our battery, but what we wanted to talk about also was what are our must-haves for equipment as well, because it's really important to make sure that you have equipment that's going to make your test procedures more efficient. So as we discussed earlier, it's really important to have equipment that should have an ability to do multi-frequency tympanometry, under 6 months 1000 hertz, over 6 months 226. I find it helpful for me. I have an auto start feature for my tympanograms. So meaning once I obtain a seal in the ear canal, the TIMP test starts automatically. I don't have to turn around. I don't have to look for the button. It just starts. And then my equipment also has audio tones that let me know that the testing is started and finished. And then if it gives me a tone right away, I know that I'm up against the ear canal, or something's plugged, something's not right. We definitely want to have the ability to test acoustic reflexes with frequency-specific signals, and then also the broadband noise for all those reasons that we discussed earlier. It's very helpful for me to have permanently set up protocols in my equipment. So for example, I have protocol 1 is my under 6 months. So it's going to automatically pull up 1000 hertz with reflex screenings. And then protocol 2 is over 6 months. So it's going to pull up 226 with reflex screenings. So it's just really helpful as far as your workflow goes to have those things in place if you have the ability to do that. So, another thing I think is really important is pump speed on these tympanometers. My first immittance bridge was one with a dial that I had to change the pressure by hand, and then I had pens. If you remember those, you had a little pen that you put in there and you had your piece of paper and it drew it for you. I thought that those were the best because they were super fast. I didn't have to wait for the machine to get the pump up to speed. It just did it. And so having something with a really fast pump or pump reset, so say I'm occluded, I pull a probe out, put it back in, pump resets right away, and it'll run the TIMP right away. That's really important for me, especially around really tiny, cranky babies, and sometimes, really anxious parents as well. Long cables is another one that's really important for me because I have a big test booth. babies are not always right next to me. Babies are being held sometimes they're being fed. So having some super long cables that have some length to them so I can get across the booth to wherever the parents are is also helpful. And sometimes, I mean, not sometimes, absolutely having probes that are lightweight. So these are tiny ears on tiny babies that weigh, you know, sometimes less than sugar, 5 pounds of sugar or flour. So having something that is super light, that isn't super heavy, and once I place that probe in the ear is not going to pull out because it's so heavy. So those are some of the other things that I like about the equipment or having that I feel are important as far as our equipment goes as well. So that concludes our talk today. We wanted to list all our references that we've displayed throughout the presentation, and we also want to thank Dr. Stiles from Boston Children's, and then Dr. Hall, who is brilliant and offers many brilliant research articles for us to read and information out there for us to access as well. And of course, we want to finally thank Natus for asking us to do this talk today. I'm going to now turn back over the presentation to Brianna. She's going to has some more slides to look at.
Thank you, Dawn. Thank you, Lindsay. Thank you both so much for taking the time. We do have a couple of questions that have come in, so let me go ahead and pull up my presentation here. We'll have time to get to a few of them today, but just in case we don't get to them all, or if you think of something later, my email address is listed here at the bottom of the screen. So that way you can contact me directly and I can pass that information along to Dr. Violetto and Dr. Bondurant. So the first question that came in, actually, it's a short and easy one for you. It's where can you find the Joint Commission on Infant Hearing recommendations?
If you go to jcih.org, which is Joint Committee on Infant Hearing, jcih.org, you will see the position statements there. So the most recent one, and I believe they're working, there should be another one coming out fairly soon, but the most recent one that we work with is from 2007, and that's right at the top of the page when you go to that website. And it's full of super useful information. It has, you know, all of these guidelines that we've been talking about in terms of when things should be done, and they have even some really good intervention and management guidelines there. So I strongly recommend, if you suspect that you're going to see kids, to at least look over that. And even if you're not equipped to do everything that's in that position statement, if we wait for every single audiologist to have every single thing possible for infants, we're never going to get these infants seen. So if you can look through it and see what you might be able to contribute to that team approach, that would be wonderful.
And I think also if you definitely look at JCIH for sure, and then but also look at AAA and then also ASHA pediatric protocols for testing. They're very, very similar, very similar. So I would also check those out as well.
Okay, perfect. And another question that came up while you were talking, and this alludes, I think, more to the maybe the adult testing that you had briefly refreshed us on at the beginning of the talk. But the question was, why would you use multiple probe tone test frequencies for tympanometry?
There's a lot of reasons that we're going to do it, but for a general population, so we went over why we would do it in an infant population, which is almost exclusively because we need accurate results. And you're just simply not going to get accurate results under 6 months of age unless you're using a higher frequency probe tone. We can use multi-frequency tympanometry in the general population to differentiate between different disorders. And so there's a lot of great information in say the CATS textbook, the Handbook of Clinical Audiometry, that walks through some of these different multi-frequency protocols. But you can, you know, if you've got an ossicular chain disarticulation or something like that, you're going to see different shapes of tympanograms with those different probe tones. But certainly for the purposes of this presentation, you absolutely have to have high frequency capability, which most tympanometers that have that are going to have at least 1,000 hertz probe tone. So you're going to want to do that so you can tell the difference between a true normal temp and a true flat temp. If you're using a low frequency probe tone, then you might see what looks like a normal temp at 226 hertz, but the kiddo really has middle ear effusion and it's just showing you some inaccurate results because you're using the wrong probe tone. So as Dr. Violetto said, you would definitely want to use the high frequency to tell the difference between an ear with effusion and not.
I second that. In my practice, before I was all peds, we definitely used multi-frequency tympanometry, so like 226, 678, when we had a suspicion that there was some mass effect in the middle ear. So perhaps cholesteatoma, perhaps, like she said, disarticulation of the aceticular chain. You can use those to examine that, and you'd see different patterns on there.
Very good. And just to piggyback, one other thing about adult testing, if you are curious about more information on adult admittance testing, Otometrics actually recorded a webinar, I think it was precisely 1 year ago, I think it was last September, by Dr. Diane Sabo. She recorded a webinar on adult admittance testing. And so you can view that webinar as well as all of our other previous webinars on the Otometrics global website underneath the education section. And this one will be available for viewing as well, I believe in a week or so, and as a recorded session. So you can always access that and get some more information on adult testing. Then the last question that I had come in just now was, and this will probably be the last one, unfortunately, we'll be able to take as we're running just this tad over here. The question is, why are you not doing reflex decay in infants?
Did you want to field this one, Dawn?
Honestly, I mean, if we diagnose some form of dysfunction as far as like the ears or the hearing goes, then we might look at doing that. But for the purpose of the diagnostic test, the purpose of the diagnostic test is to once they've failed these screenings, is to confirm or deny the presence of hearing loss in one or both ears. So as time goes on, we may come back and add that into the protocol as the child's being retested. But on initial testing, for the purposes of efficiency and what we need to learn, and whether the child will tolerate that is also a big one. It's not included in the initial battery. I don't know if you have something different, Lindsay.
Not different so much, but just to piggyback on that, really critical with any kind of pediatric testing is we are always looking at what is the next most important piece of information that we can gather for this particular child. And always with infants, because pediatric hearing loss is considered a neurodevelopmental emergency, we have to figure out what those thresholds are. So typically, as Dawn was saying, there's just not going to be enough time to include decay, and it's not going to provide enough useful information in that differential diagnosis for us to warrant spending the time doing that. Because by the time we have otoscopy, immittance, OAEs, and frequency-specific ABR, we are looking at quite a bit of time with that kiddo. So if there's something as we're gathering, working on that cross-check principle and we're gathering information about the child where we think a reflex decay could be really useful for our differential diagnosis, it might be something that we would look at down the line, but typically with this population, we're not going to get enough additional information from that particular test to warrant including it and slowing everything else down.
Okay. Wonderful. Thank you again, Dr. Violetto, Dr. Bondurant. Thank you so much for taking your time for not only presenting right now, but also preparing for this. Thank you so much. And again, if anyone has any further questions or concerns, I'm sorry, that's all we really have time for today, but please feel free to email me at brianna.young@natus.com. You can see it there in the right-hand lower side of your screen. Or I will also collect any of the other chat messages that have come through at the conclusion of this and pass those along to Dr. Violetto and Dr. Bondurant as well. So again, thank you everyone for participating and have a wonderful rest of the day.
Thank you.
Thanks.